Thank you very much. I would like to thank the organizing committee and the scientific committee for the kind invitation. It is a pleasure and honor to be with you guys here. Uh, this is my name, this is my disclosures. Just to start off about what is the prevalence of the disease. Are we safe, are we not safe? What we are looking at. From the database that I could find on my little search is there is the increase of ischemic heart disease and heart failure. Talking about Tunisia only, and it is quite alarming. This is applied to all countries, all the world. I think it is. I think it's going up. Here, like this. Don't want to ignore my colleague here. Okay. So if you see this one, there is an increase in alarming signs of about ischemic heart disease and heart failure. Again, from another registry which was here applying the Framingham risk score, the 10-year global cardiovascular risk in Tunisia population is already substantial and need to be looked at. So what is the average life expectancy of an 80 years old man if you look at it? If you guess that one, commonly we guess 7 years, 5 years, 7 years. It is around 7.7 years in the projected life. For men is less than women for obvious reasons, because they don't listen. But the average life is 87, 90 to 90. The factor, the number of procedures will increase for the cardiac surgeons, so we should be rest assured about that one. We will never be out of work. We always hear this one in news and media and other rooms, but it's not. So it will increase because of multiple factors. Number of patients, they will increase. There increase risk factor of blood pressure, smoking, diabetes. There is no single epidemiology study that I read in any country that there is no increase in those things, even with the secondary preventions. Epidemiology increase the life expectancy, improve the diagnosis of the patient, increase the income, aging of population, and physician factor that will increase our patient is using a minimal invasive and transcatheter approach. So the other thing that it pushed us a little bit further is this one. It is the nightmare for all surgeons, maybe, this valve. And the improved technology, it is good for the patients, but we should be better. We should do better than that as a surgeons. We should push the limit. We should push the boundaries. The level of minimal invasive, I'm sure everyone is aware of this one. It's level 1, level 2, level 3, and level 4. Direct vision, mini sternotomy, mini incisions. We saw some competition from our colleague, pushed it a little bit further. We still can do aortic mitral CABG, video assisted, direct incisions, robotic mitral and CABG, and we do more than that. And we will have a look at it. Level 4, which is a little bit ahead of still under investigation, which is the telemanipulation and telerobotics. Evolution of CABG has been progressive since. We started with on-pump, then off-pump, then off-pump mid-caps, then robotic, and then total endovascular robotic CABGs. Are we doing them? Yes. Not much, but still it is there. So this is the main two principles for any robotic surgery. A robot may not injure the human being, and the robot must obey the order given to by human being. But you could still blame the robot if you do something wrong. The term robot, it came from from Czech Republic, which means a labor that do meticulous work according to the orders that you give him. So when you do the robot, that means you are giving him the orders. It has been inspired from the Leonardo da Vinci when he did his first mechanical knights. Even if you see in the robot, we still use the same principles here in the arm of the robot. It have a lot of wires and and things to proceed and have the robot done. This is the very, very, very beginning of a primitive robot, and you could see how that was very primitive, and there was a lot of wires, a lot of forceps, a lot of things. There was a lot of work happened during that. What I want from this is to just see here. So it started in 1998, and now we are 2000. We started to do the TCAP. This is about the cabbage. I'm just talking about the two primary things, or two big surgeries that we do, cabbage, mitral. Started here in 1998. Now we are in 2000, and I could show you now the numbers where we at actually for the robotic surgery. And here we are after that primitive pictures. This is pretty much, this is my OR setup. You could see the robot in the middle. You are working in the side there, and you have your nurses here, perfusionists, same OR that we work at all the time. The market opportunity is increased. It is amazing, and amount of money that is put into this is a lot. And still, there is a lot of entrepreneurs that they are putting a lot of money. Here you see the cardiac surgery is 12%. Give a guess how many robotic surgery is done according to the STS data. Just last year, how many centers that they usually do mitral valve, and now they shifted to a robotic mitral valve? It's 15%. That means it's increasing. It started with the 2%, 3%, 10%. Now they are 15% according to the latest data from Da Vinci. The total robotic, this is for all procedures. That means thoracic, cardiac, colorectal, urology, everything. 750,000 cases per year in 2016. Here in 2005, and there's not much years between these. Where is the robotic technology is going? It's coming to this side, and I will leave the talk to my colleague. I think Dr. Benali, he will talk about artificial intelligence integrated with the robotic. I think that's what we reach at. I think that's the ultimate of robotics. So I'm missing, let's go back here. So I'm still missing that there is a slide here that indicates why we are away from robotic. And I could summarize it for you and mention it. You have to trust me in this one. Is cost, learning curve, and applications. Familiarity with this one, big team, lots of time in the OR. All of this will come with the more practice and practice and practice. So regarding the cost, we elevated this cost by the length of stay for the patients. And this is scripts from our hospital. And we could save around 2.3 million for our patients if we do minimal invasive or robotics. And we bring it down. Mind you that the capex, which means the upfront money that you will pay for the robot, is huge. But you could, over the 5 years with the OPEX, it will go down. So what you can do with the robot. This is live pictures from our programs. And pretty much we do all of this one. Coronary revasc, robotic assisted limb harvest, robotic assisted total endoscopic coronary artery bypass, hybrid coronary revasc, and we have a lot of experience in that one. We publish on that one. All kind of valve surgery, especially single valves. We do the atrial fibrillation and ablation. We do the intracardiac mass resections. Aortic valve replacement is still under investigation. We have done that one. We utilize the Perceval. I will do it again, not in my time now, maybe my student. I will leave it for them to work on it more and do more. Congenital cardiac surgery, we've done only one ductus. So what is the role for the cardiac surgery? This is the multi-center systemic review, and the result from doing a cabbage, either TCAP or mid-cap, or sorry, TCAP or hybrid, is more or less equivalent to the cabbage in the term of mortality. There is no good cost-effective study yet but we are still watching it. And believe me, whenever someone who starts the robotic program, your door will be knocked every day. You are using this, you are using that, you are increasing the cost, blah, 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 blah. But you could elevate this with the patient satisfaction and patient discharge. The study of Society of the Thoracic Surgeon 2006 to 2012, there is no difference between the intraoperative mortality between the robotic CABG and non-robotic CABGs. All of these data, we need them. We need it because we want to improve and empower this one. There's another study just reinforcing the idea of the CABG. Moreover, hybrid CABG, hybrid robotic CABG, or hybrid cab, mid-cab, it has been raising the bar and it's going up in the all recommendation. It's reaching now the 2B in the European Society recommendation, and 2A for the Lima to the single vessel disease. Here is the review from my beloved university that I used to be at, and the result is quite promising, and we should push the envelope for that one. In conclusion, there is no turning back. It will keep go, and it will keep grow, and we should embark on this one in the early stages so we could be part of that one. The future, there is a lot of room of improvement in this technology, and the next generation of the surgeons and their patients will be mandating that. Thank you.